Hey, good morning everyone. Welcome back to my pathology lecture, the series number 4, April. And today's lecture, our topic will be New Orleans. Sorry, I was kidding. Today's lecture, we will talk about inflammatory dermatosis. And this is the outline of my lecture topics. I'm glad that we have reached all the way to the April inflammatory dermatosis as well as vasculitis and connective tissue disorder. As a pathology resident, we spend a lot of time learning how to diagnose benign or malignant tumors. However, in medical world, such as medical kidney or medical liver, or today's topic, inflammatory dermatosis, the concepts are very different. Especially in the skin path, we need to know the clinical part that is very critical, and I believe that is one of the challenging part as a pathology trained resident to learn Dermpath. But I hope after today's lecture, you will have some general idea how we may make the diagnosis of inflammatory dermatosis. You can look at the picture on the left. This is an example of perivascular dermatitis. The disease is called erythema migrans, and you can see the skin looks very red or erythematous, and also it looks edematous as well. And why there is such a presentation? That is because the histologically you can see perivascular lymphocytic infiltration that will make the blood vessel dilated, causing this erythema. And also since there are so many inflammatory infiltrate, the skin will look very edematous or swollen. So that is a good correlation. The second example is a poison ivy on this person's extremity. You can see multiple vesicles on the patient's skin. And why there are vesicles? The reason is because the spongiosis causing vesicles in the epidermis as shown here. So vesicles on the skin, vesicles on the pathology. The third example is to show there is a thick plaque with a white or silver scale on the patient's extremity. The diagnosis is psoriasis. Why the skin looks very thick? The reason is because of the elongated epidermis we call psoriasiform dermatitis. And why there are white silver scale? That is because we have numerous parakeratosis mixed with neutrophils. So this is the third correlation. The fourth one and the fifth one, they are the immunobullous disorder. The fourth one, you can see there are flaccid bullae. After the bullae ruptured, they left over the erosions of the skin. And why the bullous look flaccid? The reason is because the separation is located at the inside of the epidermis, make the wall of the bullous very fragile. In contrast, this disorder, we can see the bullae, they are tense, and the reason is because the bullae, they are subepidermal, left the entire epidermis as the wall. That is the beauty of the dermatopathology, and we can see the clinical correlation and the pathology very well. Don't worry, we will start to talk about each individual disease. To have a better understanding about the pattern recognition of the inflammatory dermatosis, I will use a metaphor to explain. On the left, this is the satellite picture of the New Orleans, and we can imagine this is the picture the dermatologist seeing the patient's lesion. On the right, there are different four characteristic views of New Orleans, of the Superdome, the streetcar, the St. Louis Cathedral, and the Bourbon Street in French Quarter. As we can use this example as we see under the microscope. So this is a great correlation. If you have the knowledge from each picture, you can make the right diagnosis. This is the New Orleans. But things are not always perfect. Here I'm giving you 4 pictures. They resemble New Orleans. There are streetcars. There are something look like a canal street, but actually none of them are taken in New Orleans. I call them 4 mimickers. And let me tell you, they are from Cuba, St. Louis, Missouri, Savannah, Georgia, and lastly, the Charleston, South Carolina. And I can give them a pattern. I can call them a NOLA pattern. And that at this moment, you can have a list of differential diagnoses. Of course, New Orleans is one of them, but also you can list all the other cities. Looks like New Orleans. At this moment, you can only give a differential. But if your dermatologist give you more clinical information, such as if she or he told you that there is no lake or no ocean nearby, so you can give a correlation. And among the 4 differentials, Cuba, St. Louis, Savannah, and Charleston, there is only one city. There is no ocean or lake nearby. That is the St. Louis. So that is the clinical pathological correlation, and also that is the pattern recognition. I hope you understand this at this moment. So let's talk about the pattern recognition. The concept of histological patterns of cutaneous inflammatory dermatosis was developed by Dr. Bernard Ackerman, who is also considered as the founding figure in the field of dermatopathology. Following his work, nowadays we have established 12 main patterns of the cutaneous inflammatory dermatosis, including the perivascular and the vacuolar interface, spongiotic dermatitis, psoriasiform, bullous disorder but in the intraepidermal pattern, bullous disorder in the subepidermal pattern, small vessel vasculitis, nodular and diffuse dermatitis, folliculitis, fibrosing dermatitis, and 2 paniculitis we have talked about in the last lecture. Don't be scared by those different patterns. I hope after today's lecture, especially this slide, you will have a much better understanding and have a systemic way to approach to the inflammatory dermatosis. The first question I would like to ask you is, are they looking for a bullous disorder or non-bullous disorder? If your answer is bullous disorder, that's fine. That's not in our discussion today. This will be the topic for the next month. Now we are focusing on the non-bullous disorder. And in the non-bullous disorder, if the inflammatory is shown here as the diffuse and nodular, okay, we have a pattern. We call this number 6, diffuse and nodular dermatitis. If they are not bullous and not diffuse and nodular, then the next dividing point is there presence or absence of the epidermal change? If there is epidermal change, what is the main pattern? If the pattern is composed of spongiotic, means there are accumulated fluid inside of the epidermis and forming some vesicles, we call them spongiotic dermatitis. This is the pattern number 1. And if the inflammatory cells is mainly at the junction, dermal-epidermal junction, as shown here, we call this interface dermatitis, pattern number 2. And if we have a elongation of the radiages, as shown here, we call this number 3, psoriasiform dermatitis. Now let's move on to the non-bullous, non-diffuse nodular, but without epidermal change. Then there should be only abnormality in the lymphocytic infiltrate. Then the question will be, where are the inflammatory infiltrate? Are they in the superficial only, or there is infiltration superficial plus deep? So that is the question. That will subdivide the pattern into number 4, superficial perivascular, and number 5, superficial plus deep perivascular infiltration. So now, plus this number 6, we have 6 main pattern to study today. And I hope you understand at this moment. Let's pause for 1 second. Okay. Under each category, I want you to remember at least 2 or 3 very representative disorders. First one, in the spongiotic, we will mainly talk about contact or atopic. PER stands for pityriasis rosea. Tinea. In the interface, mainly is the erythema multiforme, lichen planus, those 2 disorders. In the psoriasiform dermatitis, at least we want to remember the psoriasis. And under the superficial perivascular, at least we want to remember the urticaria. In the superficial plus deep, this is more important. I hope you can remember lupus, loose, leprosy. And lastly, in the diffuse and the nodular, we want to remember the gout and the parasitic, include the granuloma annulare and the rheumatoid nodule. And lastly, we will talk about the small vasculitis, including the HSP, and lastly, the morphia. Let's talk about the spongiotic dermatitis, and the three main disorders including contact dermatitis or atopic dermatitis, pityriasis rosea, and tinea. In the spongiotic dermatitis, it can be subdivided into acute, subacute, and chronic. Let's start with the acute spongiotic dermatitis. It usually presents as itchy vesicles, as shown here. And you can see those are vesicles. And usually they are very itchy. The etiology could include atopic dermatitis, means eczema. Irritant contact dermatitis means if the person had some acid or alkaline on the skin, those can be irritant to the skin and causing this skin vesicles. Or allergic contact dermatitis, such as poison ivy. What is the histologic pattern? Histologically, you can see there is a spongiotic, as shown here. The spongiotics basically means there are accumulation of fluid, and those accumulated fluid causing those keratinocytes start to separate. And if you remember the nature of the keratinocyte, there are desmosomes hold each other. So if there is accumulation of the fluid, it looks like a sponge. And if there is a continuous increase in the fluid, when the desmosome cannot hold each other, there will be vesicle. And usually in the vesicle there can be inflammatory cells. And the inflammatory cells can include neutrophils, lymphocytes, and sometimes Langerhans cells. And the Langerhans cells is antigen presenting cells, usually is more indicate of contact dermatitis. Also there can be numerous eosinophils inside of the dermis or in the epidermis. So this is the acute spongiotic dermatitis. When the acute spongiotic dermatitis develops after a period of time, it starts to calm down, and at this moment those vesicles start to have the crust on top, and because of the itchy, the patient start to scratch and they can look more thick, as shown here. The reason is basically similar, including atopic dermatitis, as shown here. Maybe this is a little kid, and atopic is always in the differential diagnosis. Irritant dermatitis and allergic contact dermatitis is basically the same. Histologically, instead, we can still see there is spongiosis, but the vesicles, they are gone. See, you don't see those vesicles. Instead, those epidermis start to grow down. The reason is because the irritation will cause itchy, and when the patient start to scratch, and the irritant plus scratch will have this hyperplasia of the epidermis. So we call this psoriasiform. But the psoriasiform is not the regular psoriasiform hyperplasia. That is in contrast to the psoriasis. We will talk about that later. And because of the very high turnaround time, you will see those retained keratinocytic nuclei, which is the perikeratosis. And because of the fluid, there can be some serum as well inside of the crust. So this is the subacute dermatitis. After a long time, the subacute dermatitis will start to develop the chronic spongiotic dermatitis. We have another terminology for this, is the lichen simplex chronicus. They can be used interchangeably. So this is the clinical picture. You can see the dermatitis start to look very thick, and there are some scales. What is the lichen? Here is the lichen on the tree. So clinically they are very itchy and the patients start to scratch a lot. After the scratch, the skin start to have the reactive change. You can see here. So the presence of the granular layer means there is a chronic irritation. Usually the thick granular layer happens on the volar skin, means the palm and sole. But if you see those cells in the hair-bearing skin, means there is a chronic irritation or scratch. Also, we can see there is irregular elongation of the radiages. We call this psoriasiform. So those are the features of the chronic spongiotic dermatitis. I would like to add one disorder, which is the prurigo nodularis. Remember the lichen simplex chronicus we saw in the previous slide. It has a very diffuse patch. However, in this disorder, prurigo nodularis looks like a little nodules. People give this one another terminology or call this Picker's nodule, and it's just an excoriation on the very thick nodules. Histologically, it looks like a lichen simplex chronicus, but you can see those very fat hair follicles. They can be very prominent, so do not call this one a squamous cell carcinoma. And always remember, the squamous cell carcinoma in your exam is almost always the wrong answer. So single nodule of lichen simplex chronicus is the prurigo nodularis, aka Picker's nodule. Next disorder is also in the spongiotic category, which is the pityriasis rosea. It usually has a harrowed patch, which probably present as a single lesion, and the rest of the lesion following the first one. And the classic pattern is on the trunk with a Christmas tree pattern, as shown here. The etiology is unknown, but most of the people consider it is a reaction to an infection to the herpes virus. Histologically, you can use this mnemonic to remember. Sampler stands, the S stands for spongiosis, A stands for acanthosis. You can see there is a thickening of the epidermis. And a key feature of this one is the mount of the perikeratosis. And you can see perivascular lymphocytic infiltrate with red blood cells extravasated in the papillary dermis. So sampler and pityriasis rosea, or PR. There is a caveat in the inflammatory dermatosis. Whenever you see there is perikeratosis plus neutrophils, you should always look for the fungus in the stratum corneum. You don't have to have a PAS stain in your exam, because in your exam, if they want to test you on the tinea, they have to give you something very obvious on the H&E. So here is the H&E stain. You can see those are the tinea hyphae. So you can make the diagnosis of tinea. Let's move on to the category number 2, interface dermatitis. Under this category, we will talk about the erythema multiforme, lichen planus, lichen sclerosus, lichen nidus lupus, and so on. First, let's discuss what is interface dermatitis. Interface basically means the dermo-epidermal junction, this area. The interface dermatitis can be subdivided into vacuolar and lichenoid interface dermatitis. The vacuolar means the inflammation is minimal, only causing the basal layer liquefaction, or you can see those holes with lymphocytes without a lichenoid band-like lymphocytic infiltrate. In contrast, the lichenoid, it has a band-like lymphocytic infiltrate beneath the dermo-epidermal junction. Please be aware that the interface dermatitis vacuolar versus the lichenoid, they are not two separate distinct entities. Instead, they are in spectrum. So that is something we should know. The representative disorder in the interface dermatitis, including the erythema multiforme, Stevens-Johnson syndrome, toxic necrolytic syndrome, and GVHD. The lichenoid, the representative disease would be the lichen planus. This is the erythema multiforme. You can see those targetoid lesions. Usually it is induced by viral infection. And the second picture on the left is showing the person has skin involvement as well as the mucosal involvement. So this is the Stevens-Johnson syndrome. And lastly, you can see most of the skin is necrolysis. So this is the TEN, which is the toxic epidermal necrolysis. By definition, if we have the involvement less than 10%, we call this Stevens-Johnson syndrome. If we have involvement more than 30%, we call this TEN, and everything in between, we call this overlap. But some people believe this spectrum is useless. We don't change name when the patient has a development of the disorder. But for the study or the test purposes, those are the numbers you should remember. One thing I forgot to mention is that the etiology for SJS and TEN, usually they are induced by drug usage, unlike the EM, which is usually the viral infection. So let's talk about the pathological features of the erythema multiforme and the SJS and TEN. So those three under the microscope, they can look exactly the same. So without clinical history, we cannot make that definitive diagnosis. Remember the correlation thing? So this is the time we need to correlate with the clinical information. What is the percentage? What is the involvement? If the mucosa is involvement or not. So histologically, you can see the stratum corneum usually is intact. The reason is as an acute process, the stratum corneum is uninvolved. So that's why we see this normal basket wave stratum corneum. Sometimes people refer this to acute basket wave stratum corneum. And there is interface dermatitis. And because the interface dermatitis is damaging the basal layer, causing this separation. And the keratinocyte, they are necrotic. You can see that this keratosis basically means dying keratinocyte. So these are the features of the erythema multiforme, SJS, and the TEN. Once, when I was a second-year resident, I was called to UMC to perform a midnight derm frozen to evaluate Stevens-Johnson syndrome. I hope you will not encounter this situation, but if you are going to encounter this, I want to help you. So in the midnight, if the dermatologist resident is performing a biopsy to rule out SJS syndrome, mainly they are trying to differentiate the SJS from the staphylococcal scald skin syndrome, which is the 4S. Why? Because the SJS TEN, we need to treat them with steroid. As 4S syndrome, they should not give the patient steroid. Instead, they should give the patient antibiotics. That is very critical deciding point. So that's why they are performing the biopsy. And as we mentioned, the histology of the SJS, I'm not going to repeat here. But for the 4S, the histologic change is the separation should be at below the stratum corneum and above the keratinocytes, because there is antigen targeting this area. And there should not be a lot of this keratosis. So I hope you can make the diagnosis if the differential is SJS from the 4S. Another differential is the GVHD, but I think it's more of a rule out based on the clinical presentation. If the patient just had a bone marrow transplant 100 or less days ago with some GI bleeding, and that's probably the GVHD rather than SJS-TEN. So this is the section for midnight frozen. This is just a quick example of acute GVHD, and you can see there is interface dermatitis with abundant dyskeratotic keratinocyte. Histologically, this can look very similar to the one we saw in the SJS and the TEN. And actually, in real life, without a clinical history, it is very challenging to tell them apart. I don't think the GVHD will be tested, especially the grading system in your AP and the CP board exam. I think that is above your level as a pathology resident. Let's move on to the lichenoid dermatitis. The first one is the lichen planus. if you still remember the 6 P's in your USMLE Step 1, you should be able to tell they are pruritic, plaquenal, planar, purple papules, and plaques as shown here, usually on the dark skin patients. Histologically, it has a very characteristic lichenoid dermatitis. You can see this band-like lymphocytic infiltrate. And because of the lichenoid infiltrate is destroying the dermal-epidermal junction, you can see there the junction start to look blur, and you can see this sawtooth-like pattern of the reedy ridges. And one unique feature is in the textbook, you should have no parakeratosis in the stratum corneum. You should have no eosinophils in the lichenoid infiltrate. That is in your exam and in your book. If you see those features, you should think a lichenoid drug eruption. In the classic, at least in your exam, the lichen planus, they should have no parakeratosis, they should have no eosinophils. Next disorder is the lichen sclerosus atrophicus. Remember, this one is a U instead of I. Not lichen sclerosis, but lichen sclerosus. And the abbreviation, sometimes if you got the biopsy requisition from those dermatologists or dermatology resident, they like to put abbreviations. LS, LSA, LSEA, all of them are the same thing. So the LSA usually affects the vulvar and the perianal regions of an elderly lady. Presents as white sclerosis here, A, and atrophic as shown here. So histologically, you can see, as the name implies, it has atrophic epidermis. It is thin, and you can see it lost the reedy ridges. You can see there is a edema beneath the epidermis, making this a very pale color, and you can see there is a sclerosis. Looks very dense, and also there is a lichenoid infiltrate. So people call this one a red, white, blue sign. Here is the picture of the Netherlands national flag, resemble this lichen sclerosus. If this happens in the male in the foreskin, we call this a different name called balanitis xerotica obliterans, but they are basically the same thing. This disorder we are going to talk about is the lichen niditis. This is a very cute disorder, but it's quite common, but we don't see them very often in our daily work. You know why? It's because when it looks very classic, the dermatology people, they don't biopsy it. So this is a skin showing those small skin colored papules, and common location is the upper extremities. You can see those little very small papules. Under the microscope, you can see this. It's a lichenoid, but they have those like a round ball-like pattern. So also the epidermis, they have a sawtooth, very pointy reedy ridges, and resemble the ball in the claw sign. So in your real life, probably not very commonly seen, but I think the test like this disorder because histologically it's so classic. Ball in claw sign, lichenitis. We have finished our spongiotic and interface dermatitis. Let's move on to category number 3, psoriasiform. And this category, I hope you can remember two main disorders. One is the psoriasis, second one is the pityriasis rubra pilaris, aka the PRP. Also, I listed the mycosis fungoides here. We know that mycosis fungoides is a cutaneous T-cell lymphoma. It's not a dermatitis, but in real life, the mycosis fungoides can be misdiagnosed as inflammatory dermatitis for many years, and the common presentation is psoriasiform dermatitis. So keep that in mind. A long-lasting psoriasiform dermatitis, you need to rule out mycosis fungoides. The first disorder in the psoriasiform dermatitis is the psoriasis. Clinically, it presents as round to oval-shaped lesion, as the picture shown here. Also, you can see there is silver white scales on top. I hope you still remember this terminology, auspice sign. Basically, it means when someone scratch off the white scales from a thick plaque, they can see the pinpoint bleeding. This picture is taken by dermoscopy, which I consider it as a microscope of dermatologist, and you can see those pinpoint bleeding very clearly. This is a very useful terminology to remember because it has a great correlation with the histologic finding. So the thick scale, why? Because there is a elongation of the radius, and by definition, in the psoriasis or psoriasiform dermatitis, those elongations should be regular, and some people describe them as elephant legs. And why there are scales is because there are perikeratosis on top with neutrophils. Neutrophils is a very important feature in diagnosing psoriasis. And third, when we talk about when we scratch off the thick scale, why it is easily scratched off? It is because there is no granular layer. Do you still remember when we talk about the LSC? What did I say about granular layer? That usually means they are trying to hold each other very well. So if there is no granular layer, they cannot hold each other. So it easily be scratched off. Then lastly, why there is pinpoint bleeding? That is because we have tortuous capillary vessels in the papillary dermis with a thinning of the epidermis on top of this epidermal papillae. So that is thinned suprapapillary plate plus tortuous blood vessel causing this pinpoint bleeding. So all those clinical and pathological correlation I think is perfect in the auspice sign, which can help us to understand. It is very important, so I would like to show another picture to repeat all those points. First, you can see those regular elongation of the radius resemble elephant legs. Second, we see those blood vessels, dilated tortuous capillary blood vessel. Third, we see thinning of the epidermis on top of this papillae. And lastly, we can see the perikeratosis mixed with neutrophils in the scale and no granular layer. So classic psoriasis. Also in the category of psoriasiform dermatitis, there is a very interesting diagnosis called clear cell acanthoma or pale cell acanthoma. Even though there is OMA in this acanthoma thing, but nowadays people believe this is more likely to be an inflammatory dermatitis rather than a true neoplasm, and probably it's just inflamed psoriasis. And histologically, it is very, very unique. And even though it's not very common in daily practice, but I think if the board exam give you this, you should be able to recognize it at one peek. So the feature is it is a very sharp demarcated lesion as shown in this low magnification, and high magnification you can see this psoriasiform elongation of the radius and some perikeratosis. And one very interesting feature is you can see the sharp demarcation between the lesion from the regular normal skin. So sharp demarcation and looks like psoriasis but single lesion. Diagnosis is clear cell acanthoma. Next disorder is pityriasis rubra pilaris. It starts with multiple scaly patches with prominent follicular plugging as shown here, and they start to join together and forming larger lesions. You can see this probably the patient is experiencing some erythroderma. Histologically, it looks like psoriasis. The perikeratosis look like psoriasis, but there are two things they are very unique. First is they have the follicular distribution. You can see this is a follicular plaque which correlate with this follicular plaque. Second thing is you can see there are some horizontal parakeratosis and skipping some area, which give you the pattern of a checkerboard parakeratosis. I know this sometimes use a lot of imagination. Some people just use the checkerboard as a buzzword, but to me it's not very helpful. I hope you can remember this follicular plugging thing. So remember, if you have something looks like psoriasis but with a prominent follicular plug, think about this PRP. And I know I have shown this picture already, but let's look at it again. See, those are not elephant legs. Some of them look slender, some of them look thicker and fatter. So this is irregular psoriasiform. Okay, this is a chronic spongiatic dermatitis, aka lichen simplex chronicus. Okay, let's move on to the category number 4, superficial perivascular dermatitis. Includes the urticaria, drug eruption, and the viral exanthem. To be honest with you, I don't think the test will give you this diagnosis, superficial perivascular dermatitis. Why? The reason is because the changes are too subtle. For APCP pathology resident, I think this is above your level. But it's good to put it here to complete the entire picture of pattern recognition. So from this low power, you see it has inflammatory cells mainly at the superficial portion with a perivascular distribution. And when we zoom in, you can see again perivascular lymphocytic inflammation with scattered cells, not many spongiosis, not many lichenoid inflammation. And when we zoom in again, they are lymphocytes. So superficial perivascular dermatitis, lymphocytic predominant, we should think two disorders. First is the viral exanthem. Second is the drug eruption. How can we tell them apart? It's very difficult if you don't have the entire clinical picture. But in general, if the patient is a younger individual, you should think more viral. If the person is an older individual, think drug. If you see eosinophils, you think drug. If you see no eosinophils, think viral. That's the general. I think that's enough for this disorder here. Another disorder also listed in the superficial perivascular dermatitis is the urticaria. It usually presents as those hives, and the classic urticaria, they should not last more than 24 hours. If it's lasts than more than 24 hours, think something else. And they are erythematous pink or red, wheels of variable size and shape. Sometimes scratch or some pressure can cause this change, which is urticaria. Histologically, you can see the superficial perivascular inflammation. But the inflammatory infiltrate is not only lymphocytes, but there can be abundant neutrophils. Actually, the neutrophils and eosinophils, those are the two main inflammatory cells in urticaria. Also, there can be some mast cells. So if you are looking at a skin biopsy with very subtle change, you see those inflammatory cells composed of neutrophils, mast cells, and some lymphocytes, and slight dermal edema, you call urticaria. I think that will be your right choice. Very subtle, though. Let's briefly talk about the drug eruption. In real life, drug eruption can be very common, but I don't think it will be tested on your board exam. The reason is the drug eruption without a proper clinical history is very hard to rule out or rule in, and they can resemble other disorders. There is no characteristic feature to say this is definitively a drug eruption, so that's the reason. And as the name implies, urticarial drug resemble urticaria, lichenoid drug eruption resemble lichenoid dermatitis, psoriasiform drug eruption resemble psoriasis, drug-induced lupus means this looks like lupus, but it is induced by drug. So how can we tell them apart? and I would say very hard, but with the presence of eosinophils can be a hint, but not always 100% correct. And there are so many types of drug eruption, up to 30%. Just keep in mind, drug always in the differential, but without history, hard to rule out or rule in. Next category is category number 5, superficial and deep perivascular. Under this category, people usually use lots of L's. And for your level, I think understand those 6 L's are important, including lupus, Louis, that is another term for syphilis, leprosy, lice. I put lice because it has L, but also remember other bugs can cause similar reaction, light reaction and lichen striatus. And those top 4, they are the most important ones. Next one is the lupus erythematosus. It can have a spectrum from the single lesion, which we call discoid lupus, and a subacute without systemic involvement called subacute cutaneous lupus, and systemic lupus erythematosus, as one shown here, may involve the systemic organs. And histologically, I think is very characteristic. If you see this in low power, I hope you can make the diagnosis within 1 second. Why? Because the histologic changes are so characteristic. It has superficial plus deep, periadnexal, and perivascular. You see here, superficial and deep, perivascular, and periadnexal. So that is, we call this one a pan-inflammatory. And if you do the direct immunofluorescence, it should have the IgG, IgA, IgM, C3, full house. So even though it's a very complex disorder, but for your exam, you should be able to recognize the picture at low power. And you need to know other features, such as what are the antibodies. Probably that will be a crossover with your CP exam. Another picture to demonstrate the superficial and deep perivascular and periadnexal plus some lichenoid inflammatory infiltrate and some pigment incontinence. Always remember, whenever you see there is pigment incontinence, means the basement membrane has been destroyed, causing the pigment dropped into the dermis. So again, pan-inflammatory dermatitis, which is the lupus. Next disorder is an important disorder called syphilis. When the person initial infected with the syphilis or Treponema pallidum, there can be a chancre, which is a pinless on the genital area. But this area, they don't have to biopsy to make the diagnosis of syphilis. When we got the biopsy, usually is the second stage. The second stage syphilis usually presents as those bronze-colored patches or papules on the palm or the hand. And when they biopsy, you can see the histology of the syphilis second stage can vary based on, they can have a superficial plus deep pattern, which is our category here, but also there can be a very predominant interface change, psoriasiform and granulomatous. So people call melanoma as a great mimicker because they can present very different morphology. Syphilis, we also call this a great mimicker because it can also present very differently. And what is the hint to call a syphilis is the plasma cell. Presence of plasma cell can always give us a hint to make sure it is not a syphilis. And also, usually the syphilis do not have eosinophils. That is not a hard rule, but it's from our experience. And here you can see those slandered, elongated reedy ridges. And people remember this as a sexy reedy ridges, plus some plasma cells here, which is syphilis. Not equal to syphilis, but give you a hint. You need to do some immunostain to rule out the syphilis. And this is the Treponema pallidum TPAL immunostain, which can highlight those syphilis, usually at the reedy ridges. And next disorder can also give you a pattern of superficial plus deep, which is the arthropod assault reaction. The assault reaction is more accurate than a bite reaction because some arthropods, they don't bite, they sting. That is, some people told me. So histologically, you can see the perivascular superficial plus deep infiltrate plus abundant eosinophils. Those can give you a hint of a bug bite reaction. And if you see the pattern has a V-shaped, something like this, that is more supportive of arthropod bite reaction. But remember, as we mentioned, the drug reaction can appear similar. So whenever we diagnose drug eruption, we put a drug, we put a bug, and when we diagnose a bug bite, we also put drug reaction as well. The next disorder is the leprosy, and clinically it can present as hypopigmented patches with sensation loss or numbness, as the picture shown on the right. And if the patient has no treatment, at a late stage there can be some deformity in the face and in the extremities as well. So if you remember in our USMA step 1, the leprosy is actually a spectrum. If the immunity of the patient is strong, there can be tuberculoid leprosy. And in contrast, if the immunity is weak, then the patient can present as lepromatous. So this picture, histologic picture, is showing a lepromatous leprosy. Because if they give you a histology picture of tuberculoid, you have to, it's hard. They have to give you either AFB positive, which is hard to detect the leprosy in the tuberculoid, or they have to give you other negativity to rule out sarcoidosis. So to me, if I'm designing the exam, I should give you a lepromatous. That is what I think. So the leprosy, histologically, it should have the superficial plus deep. And if you notice, the epidermis is uninvolved. So when you have abundant dermal stuff without involvement of the epidermis, we call this Grant's zone. That is usually can be seen in leprosy and some B-cell lymphomas. And third, those can be two buzzwords, can be tested in your exam, which is the globin, which means there is a ball filled with lepromatous organisms. And there are some histiocytes, like foamy histiocytes, those called the Verhoeven cells. And if you want to stain them, this is the fight, which is the modified AFB, can detect those leprosies. Okay, let's move on to the number 6, diffuse and nodular. In this category, definitely the sarcoidosis is involved, but as in other part of the body, the sarcoidosis is diagnosis of exclusion. So I will mainly talk about the gout as well as the palisaded granuloma. First disorder under this category is the granuloma annulare. So the name implies it has granuloma, and the clinical presentation is an annular or circle of lesion. Under the microscope, you can see seems like there is something round in the dermis, and it has outer layer, looks like a palisaded, like a picket fence at the periphery with some mucin inside. So when we zoom in, we can appreciate those palisaded histiocytes better, and also some mucin. When you have this pattern, palisaded granuloma histiocyte surround some dermal collagen and mucin, that is very characteristic of granuloma annulare. So GA. Next, the picture is showing the gout. Even though I'm showing the deformity in the hands, but the dermatologist will not biopsy those swollen joints because they know they are the gout. The usually scenario is the gout patient has a nodule on the ear or head and neck area, and the dermatologist could not tell if this is a basal cell carcinoma, squamous cell carcinoma, and they biopsy this area and send to us. So under the microscope, you can see there are some palisaded granuloma at the periphery, but you need to go to high magnification to see those amorphous but feathery like gray to blue material. This is characteristic of the uric acid crystal remnants. They are not real uric acid crystal because the formalin during the processing, they will wash away all those uric acid crystals. If you really want to see them, you can do either one of the two things. First, fix them in ethanol instead of formalin. Second, you use a very thick section and process them with the regular processor. If you go to Dr. Love's office, you can see on the wall there is a uric acid crystal. That is a picture of mine. I took those pictures. Next disorder is the rheumatoid nodule, and the common location is near the joints. And when they biopsy this area, you can see there is also a palisaded granuloma with very eosinophilic fibrin, but there is no mucin. That is a differential feature to tell it apart from the granuloma annulare. Let's move on to the vasculopathic and the purpura category. This is the broad category of the vasculopathic, including non-inflammatory purpuras, including senior purpura or actinic purpura. And the second big category is the vascular occlusive diseases or vasculopathy, including atrophy blanche or protein CS, those occlusive disorder. And the third big category is the vasculitis, including the leukocytoclastic vasculitis and the Hernock-Klein purpura, etc. So because of the time of this lecture, I cannot go to very details. So I'm going. The first disorder is the solar purpura, usually presents at the forearm, and which more common in the light skin patient. You can see those subcutaneous hemorrhage. And in the solar purpura, mainly you see the extravasated red blood cells without associated vasculitis. That is solar purpura. You can see those solar elastosis changes as well. This is another way to classify the vasculitis. And we can subdivide the vasculitis into two big categories, including the small vessel vasculitis and medium-sized vessel vasculitis. And the two characteristic disorders are the LCV and the HSP in the small vessel. And in the mid-vessel vasculitis is the PAN. So let's talk about category number 7 in today's lecture, which is the leukocytoclastic vasculitis. As the picture shown here, in the patient's lower legs, there are multiple purpuras. And histologically, you can see there is significant vascular damage. And the features of vascular damage including the fibrin deposit in the vascular wall. And because of the vessel wall was damaged, there can be abundant extravasated red blood cells inside of the dermis. And because the damage was induced by the neutrophils, you can see the neutrophils as well as the karyorrhexis, which is just the nuclear debris from the neutrophils. So those are the features of LCV. In contrast, the LCV was induced by mainly neutrophils. The Hernock-Klein purpura HSP, this is the most common IgA vasculitis. So it's induced initially by the IgA complex deposition in the vessel wall, then recruited those inflammatory cells to destroy the vessel. So IgA is a key component. And typical age of this disorder is in the childhood. Also, there can be systemic involvement, including the bone, the joint, and some intestinal bleeding as well as the renal bleeding. So to make when we make the diagnosis, the treatment not only on the for the skin but also for systemic therapy. But histologically, you can see similar changes, including the vessel damage and the nuclear debris or karyorrhexis and some neutrophils at the blood vessel wall. And this is a slide to show the damaged blood vessel with a nuclear debris around this area. Also, you can see there is IgA deposition in the blood vessel, small sized blood vessel, and confirm the diagnosis of HSP. Now, let's go to the connective tissue disorder. First disorder in this category is the morphea/scleroderma, what's the difference between the morphea and the scleroderma? And the answer is morphea usually means it is localized, no matter it is a patch as the first picture, or it is linear as the second picture on the forehead. Those we call this one morphea. But if there is more diffuse pattern, not only the skin is involved, but also there are some renal symptoms plus some esophageal stricture and renal involvement, we call this diffuse scleroderma. And histologically, you can see the biopsy is a squared punch biopsy. Why it is squared? Usually you can see the squared punch biopsy in two situations. One is the morphea scleroderma, the second is the punches from the back. But there are other features, including very thick collagen. And also you don't see the fat surrounding this adnexal structure. We call this trapped acrine glands. And also you see plasma cells with some lymphocytes infiltrate in the dermis. So those are the features of morphea. Last but not least, let's discuss about two disorders side by side. The first one on the left is the hypertrophic scar. The one on the right is the keloid. Features to diagnose a hypertrophic scar is when the collagen bundles are aligned horizontally, or people call east to west, and the blood vessels, they aligned south to north, or people call this vertically oriented. Those are the features of hypertrophic scar. In contrast, in the keloid, everything else can be the same, but one feature is very unique. Is in the keloid, you can see this very thick hyalinized, or people call this ropey collagen or bubblegum collagen. It's basically the same thing. When we see this type of collagen, we give diagnosis of keloid. Usually happen in the dark skin patient. Okay, that concludes our today's lecture. I understand it has a lot of information, and probably you have to review this lecture again. But let's quickly recap what we have learned today. First, we talked about the pattern recognition, and we mentioned there are different types of dermatitis. Under the spongiotic, we have atopic, of course, allergic contact and irritant contact, prurigo, which is a single lesion, pityriasis rosea, which has the simpler pneumonic. Under the interface dermatitis, we have the EM-SJS-TEN, which can be associated with late-night frozen cause, lichen planus, which is the lichenoid inflammation, lichen sclerosus, which is the white patch in the vulva area, can be a precancerous lesion. Lichen nitidus is the ball in claw sign. The psoriasiform dermatitis, the characteristic disease is the psoriasis, and the single lesion is the clear cell or pale cell acanthoма. And if we have the follicular plugging, that is the pityriasis rubra pilaris. If in the superficial perivascular disorder, in a younger individual, we think it's mostly viral. If that is an older individual with abundant eosinophils or several eosinophils, it's probably a drug reaction. If you see there are neutrophils inside the blood vessel, outside the blood vessel, in the interstitium with perivascular, superficial perivascular distribution, we think urticaria. And if the distribution is superficial plus deep, we think those several else, including lupus, Louis, leprosy, and lice, which include other bug bites reaction. And if you see a diffuse nodular pattern, we think granuloma annulare and gout and rheumatoid nodules. Sorry, should not be RA. And the vascular disorder, we mentioned the LCV, HSP. Sorry, because of the time, I could not include the PAN here. In the connective tissue disease, we talked about the morphea, which has the squared biopsy, the scar and the keloid. The latter has the ropey bubblegum collagen, and that is the recap of today's lecture. And again, thank you so much for your attention. If you have any suggestions or any questions, please again feel free to reach out to me. This is my email and my cell phone number, and I'm glad that you finished today's lecture, and see you next time.